Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll look at the NICE updates published in October 2025, focusing on what is relevant in primary care only. And this time, there hasn't been an awful lot that is relevant to primary care, only an update to the quality standard on head injury. So we'll cover just that. Right, let's jump into it. The updated quality standard on head injury covers the assessment, management and rehabilitation after a head injury. While much of it applies to secondary care, there are important areas where we play an important role in primary care. This updated quality standard focuses on the NICE guideline on head injury and rehabilitation for chronic neurological disorders. For GPs, the main message is on recognition and referral. When a patient presents after a head injury, the standard reinforces the importance of same-day assessment and appropriate referral for imaging. The thresholds for CT scans are unchanged, but we should ensure rapid referral if the criteria are met. But what exactly are these referral criteria? Let's have a look at them. The criteria can be divided between emergency referrals and urgent referrals, depending on whether imaging should be done within 1 hour or within 8 hours. Let's look at the emergency referral criteria first. They may appear fairly obvious, but it's still worthwhile going through them. For adults, that is for those aged 16 and over, we need to do a CT head scan within 1 hour if any of the following risk factors are present. A Glasgow Coma Scale score of 12 or less on initial assessment, a Glasgow Coma score of less than 15 at 2 hours after injury, a suspected skull fracture, a post-traumatic seizure, focal neurological deficit, more than one episode of vomiting, and any worrying signs of a basal skull fracture, such as hemotympanus, panda eyes, cerebrospinal fluid leakage from the ear or nose, and bruising of the mastoid process, also known as battle sign. For children under 16, in addition to what has already been mentioned, we also need to do a CT scan of the head within 1 hour if any of the following apply: a suspicion of non-accidental injury, Glasgow Coma score less than 14 or less than 15 for babies on initial assessment, Glasgow Coma score less than 15 at 2 hours, a tense fontanelle, and for babies under 1 year, also a head swelling or laceration more than 5 centimeters. Additionally, a CT scan should be done within 1 hour if children have more than one of the following risk factors: witnessed loss of consciousness more than 5 minutes, abnormal drowsiness, 3 or more episodes of vomiting, dangerous mechanism of injury, amnesia more than 5 minutes, and any bleeding disorder. Now let's look at the urgent referral criteria, that is, when a CT head scan should be done within 8 hours. For adults, we need to do a CT head scan within 8 hours of the head injury, or within 1 hour if they present more than 8 hours after the injury, if they had loss of consciousness or amnesia, and they also have any one of the following factors: age 65 or over, any bleeding or clotting disorder, including anticoagulants, or a dangerous mechanism of injury, for example, a pedestrian or cyclist being hit by a car, a fall from more than 1 meter, a fall from more than 5 stairs, or more than 30 minutes retrograde amnesia before the injury. Additionally, even if there's no other indication, we should consider a CT head scan within 8 hours of injury, or again within 1 hour if presenting more than 8 hours after the injury, for anyone on anticoagulant treatment. This includes warfarin, DOACs, heparin, and antiplatelet treatment, but excluding aspirin monotherapy. In practice, this means that if a patient comes with head trauma, we will need to identify if any of these thresholds are met and refer them appropriately via A&E or the emergency department for imaging. Our role is not to decide whether a CT is indicated or not, but to pick up risk factors and expedite referral. Now, going back to the quality statements, the rest of them simply emphasize the role of rehabilitation. In this respect, in primary care, we should ensure that referral to community neurorehabilitation or therapy services happens in a timely fashion, and that rehabilitation plans and shared care arrangements are in place. In summary, the update doesn't change the imaging thresholds, but for us it emphasizes follow-up, rehabilitation, and long-term management after a head injury. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching, and goodbye.